Okay, good afternoon and welcome to the February 27th OEH seminar. I'm really pleased to welcome our presenter today, Dr. Renee-Louise Franche, who is a good friend and longtime colleague of myself, even though I can't still pronounce her name properly. But we've been working together in one form or another for almost 15 years. Dr. Renee-Louise Franche is a senior psychology advisor at Worksafe, BC, and a consultant in work disability prevention and occupational health. She holds adjunct positions at both the School of Population Health here, as well as at the Institute for Work and Health in Toronto. And even though she is now active in Worksafe BC, she's really had a significant impact in terms of science and research in this area, with over 50 peer-reviewed publications that have been published in international and national peer-reviewed journals. Dr. Franche's work focuses on developing a better understanding of how organizational, healthcare, insurer, and individual factors contribute to safe, sustainable, and healthy return to work following injury or ill health. She has led the development of best practices for return to work and stay-at-work intervention, and has led a cohort study of injured workers, both of which has had significant impacts on policies and practices across multiple compensation systems and with respect to employers. Throughout her career, she has been committed to bridging the gap between research and practice by bringing evidence-based practices to a wide range of audiences and by including multiple stakeholder perspectives in the processes, from frontline workers to researchers through to policymakers. So welcome. Look forward to your remarks.
Thank you, Chris, for a very lovely introduction. Well, good afternoon, everyone, and thank you for inviting me to your seminar. And I just hope that the sound is okay for you, and I'm going to get used to that reverberation. I'm really loud, eh? Okay. So today what I'll be talking about is really providing an overview of mainly return to work research and best practices, but I've decided to add a little bit of a slant to it and talk about multimorbidity and chronicity. Maybe for my own sake, just to add to my own entertainment, to add something different to return to work. But I do hope that there'll be a bit of something that's new for everybody here, and I've really tried to gear this presentation for a very wide audience. So I'll first start by defining the problem in the workforce when it comes to multimorbidity and chronicity of health conditions. I'll talk about work disability prevention and return to work, the best practices, overview of research findings, and then I'll just discuss an example of a study that I think is a good example of the multiple factors that are at play in the return to work, which is actually focused on Canadian nurses' study, and we'll be talking a little about moving to solutions when it comes to return to work. So what is multimorbidity or comorbidity? Sometimes people kind of use those words in interchangeably, and essentially multimorbidity is the presence of multiple health conditions. It's been assessed in three main ways, dichotomous, so you have multimorbidity or not. The count of conditions, so you count the number of conditions, and also when you factor in the severity or the impact of the condition. So very different ways of measuring multimorbidity. And comorbidity is really the idea of choosing an index condition, and then you look at what other conditions are present in this person. So it's slightly a different context, but I think it's important to appreciate the difference. Multimorbidity, so having more than one health condition, is associated with lower quality of life as opposed to having just one or none. Decreased workability, as we'll see. And it's really, I think what's important to realize, it's more than the sum of the disease in a way. So the burden of multimorbidity, examples of that are things like polypharmacy. If you're on multiple medications for multiple conditions, clearly there'll be some interaction effects that are not always known by your pharmacist, your physician. You might have to learn about it in a very personal way. So that always complicates the picture. After, for instance, surgery, people who have multiple conditions, obviously will take longer to recover. However, I think the system, the healthcare system, is poorly adjusted to this. The specialist approach is focused on, one condition. They really take a very condition-specific approach. And for that reason, the treatment that these individuals receive is often very fragmented, incomplete, and sometimes inefficient. And the clinical guidelines typically for conditions are often written in a way that's very kind of single-focused as well. One source of excellent information about multimorbidity I've found is actually from a center on multimorbidity where Boyd and Fortin are, which is in Quebec and Sherbrooke, and I found that they really have a very nice website and research center and very nice resources. So is this a big problem? Well, kind of, yes, given that 9 million Canadians, or 1/3 of Canadians, have one or more of the following chronic conditions. So arthritis, cancer, chronic COPD, diabetes, heart disease, hypertension, and mood disorders. So clearly all conditions were very high impact on quality of life and work. And I'm assuming for some of you this is not very big news. What does it mean for Canadian workers? I think an interesting way to look at it is just to look at how many people less than 50 years and over 50 years have chronic conditions. So clearly arthritis, back problem, and over 50, and high blood pressure are very frequent in people over 50 years old. If you look at one condition versus two conditions, you're seeing a fair amount of people even less than 50 years, so close to 25% who already have one health condition under 50 years old. And there's certainly an increase for over 50 years old, which is 30%. And then if you look at two conditions or more for over 50 years old, you have about a quarter of people who have this. So this is not uncommon to have a lot of conditions. I think that's the main point that I want to bring, is that lots of people in this classroom are walking around with one or two or three health conditions. If you look at over time, the increase in prevalence, these lines actually kind of look like a little bit flat, but if you look at the increment over time in percentage, they're actually not that flat at all. If you look at high blood pressure and diabetes, you're seeing increases of 164% and 107% between 1994 and 2007. Now, I apologize for the fact that 2007 is still a bit dated, but this trend has continued. So we're really clearly seeing an increase of prevalence in these conditions. One of the driving force being age due to the changing demographic of the Canadian population. So if you combine aging with the changes in work environments, there's been a lot of descriptions of how work environments have intensified in its work pace, pressures to learn new skills, largely as a result of technological advantages and IT changes and restructuring. And in a way that kind of creates the conditions for a perfect storm where you have the aging of the workforce and stressful and changing work environments. So what does that mean for workers with chronic conditions? There is an excellent researcher in Toronto, Monique Gignac, who's done a lot of work, particularly with people with arthritis, who's shown that people with chronic conditions, and in this case more with arthritis, are very vulnerable to role strain and overload. So role strain related to more work demands, and overload more related to kind of the amount of demands, the amount of demands. Role conflicts, so we talk a lot about work-family balance. People with chronic conditions are particularly vulnerable to those stressors. And also disintegration of social network. What we find with people with chronic conditions is that typically they're going to start letting go of their social life way before they let go, for instance, of their work. And they're going to hang on to that work because it really does give them a sense of normalcy. So work is actually something that they really, really do want to do in terms of their activities. We've also found that people with chronic conditions, with more recent research by Peter Smith, that they seem to have a higher incidence of work-related injuries for workers with back arthritis and diabetes, and they have a slightly more prolonged recovery time after for older workers after work-related injury. So now we're stepping into the work injury mode. And I do want to mention, just because I work at Worksafe BC, doesn't mean that all of what I'm discussing is about work-related injuries. This is the first time that I actually mention it. So I've really tried to kind of take a very broad approach for this audience. The impact of chronic conditions, quite high in terms of productivity, quite high in human cost. There's certainly an impact on economic impact of decreased workability and a negative impact on quality of life. And again, the message that we're getting from these people, whether it's qualitative research or quantitative research, is that they're invested in keeping that job attachment. So let's see what the Canadian policymakers have done for those people in the last, let's say, 10, 12 years. And I went through the main documents produced by Canadian policymakers. From 2004 to 2012, what I found was that there was very, very little about work in these types of reports, whether they were reports for academics, policymakers, or a wider audience. So for instance, in the Chronic Disease Prevention Alliance report, there were 3 pages out of 121 talking about work for people with chronic conditions. In a Health Council of Canada report on self-management support for Canadians with chronic health conditions, there was nothing on work in a 60-page report. These reports, it's not that they were useless at all, it's that they were really focused on the design of healthcare services, on prevention, and on self-management, which are very good things to focus on, but the work element really wasn't on their radar. This has changed in the last 2 or 3 years. For instance, the Public Health Agency of Canada, their 2013 report, does mention that they are planning to address workforce issues as part of their Preventing Chronic Disease Strategic Plan. So that is definitely an objective in there. And I think last week you had someone here coming to speak about survey of living with chronic disease in Canada. There are questions in there about work limitations and work restriction. So slowly, I think the work is coming onto the agenda of Canadian policymakers who are concerned about chronic conditions. But if the chronic condition research policy community is not doing still that much for return to work, what is the return to work community doing for chronic conditions? So I've really kind of seen those 2 areas of research being fragmented, and in the last few years we're starting to see a bit more of a common focus. So I'm going to step back a little bit and say that in return to work research, which I've been involved for about 15 years, there are certain unspoken assumptions that were, I think, there for a very long time, was that most health conditions are acute, and then a work absence episode is a discrete time-limited event. And those 2 assumptions turn out to not be that based on facts. Most health conditions are acute. I think this really stems from the fact that a lot of the research has been funded by workers' compensation boards who mainly address musculoskeletal disorders where there's definitely an acute onset. But to say that those are acute and have a finite end is not really based on fact, in the sense that many of these conditions go on to have a chronic course or chronic episodic course. And as we'll see, here recurrences of work disability is associated with these health conditions is the norm. Now, these numbers of recurrences are based on workers' comp's data, where they're defined as the reopening of a claim or sometimes a new claim, but that would be the definition. In the cohort study that we ran at IWH, we found that the 6 months post-injury of a workplace injury, the recurrence rate of work disability for lost time claims was 38%. And then at 24 months post-injury, it increased to 60%, with about 4% of these people never have returned to work. Now, this is really, really in sync with everything else that's been published about recurrences of work disability in lost time claimants. So clearly, it's quite high. And the cost of recurrences of work disability is also high. They're quite disruptive. So for an employee to stop work, go back to work, have another failure in a way to return to work, it's quite discouraging. It does really decrease their sense of self-efficacy and also maybe motivation to try to go back to work again. For coworkers around them, initially with people who go back to work, you'll notice that the coworkers are really supportive in the best places and they want to help, but they kind of get burned out after a while, especially if this person keeps coming on and off and on and off. And the organization can also experience what I call organizational fatigue. It's like, oh yeah, you know, Miss So-so is still kind of off work. So there's the expectation that these conditions are acute actually sets the stage for those discouragement, that fatigue, that disillusionment, and a fairly negative experience. So I think it's important to, in a way, rectify that perception and to acknowledge that a lot of these conditions are actually chronic or chronic episodic. So I'm going to step back even more here just to give you a snapshot of, in a way, the history of return to work conceptualization and research. So I would say that 15 years ago, we still had a very medical approach to return to work. It was rehab, it was physical, and the thought of talking about the employer being involved was really very far from people's thinking. In 1997, Patrick Loisel, who is now based in Montreal, did the first return to work cluster randomized controlled trial. And he really showed quite well that medical or clinical interventions alone were less effective than interventions which were based in the workplace to help people go back to work. So he really was kind of a pioneer in this field to break that silo of medical and clinical focus. Interestingly enough, he's an orthopedic surgeon, so I think he just saw the limits of his own kind of training there. And I think that was part of the path that led to the 2001 WHO ICF International Classification of Function, Disability, and Health. And this is really the main kind of world-accepted model of disability, and it contributed in a positive fashion to demedicalize work disability. So I'll kind of give you an idea of what that looks like. And I'll give you an example of actually a worker that I was involved in this case as a psychology advisor at Worksafe BC. So the model starts really with the establishment of the pathophysiology, you know, the clinical condition. In this case, it was post-traumatic stress disorder, and I've purposely chosen a mental health condition because I think that's maybe the most kind of challenging conditions to deal with at this point and return to work. So, and I've changed some of the circumstances of this worker. It's very easy to identify workers. So it's, if you think that you know this person, well, you probably don't. So this young man, who was about 25 years old, was working on a fishing ship, operating somewhat, heavy machinery, and there was a workplace accident. He was actually thrown in the water. His father was working on the boat as well. They were both physically injured. He ended up having pain in his leg, but they were also extremely traumatized because they really almost drowned, and it was, that was kind of the main condition, was post-traumatic stress disorder. So if you look at this model, it talks about impairment. So in this case, impairment could be ability to maintain concentration, memory, focus under stressful circumstances. So his cognitive functions would be intact in a stress-free environment. If you test him on a neuropsych testing, he'll do fine. But if you place him back in that work environment where there's lots of triggers, of that trauma, he won't be able to focus and concentrate. So there were clearly activity limitations that were associated with this condition, namely to go back in the same workplace environment. He did get treatment, and I won't get into that much, but I'm just trying to explain the model. So in terms of role participation, his participation in the role as a worker was clearly impacted. What the model really focuses on is a focus on function. So it's less concerned, about the pathophysiology of things. It's really more concerned about what this person can actually do, and it highlights the environmental interaction with the person. It's really about a person-environment interaction. So in this case, what was interesting was that in his family, there was a history of somebody also dying of an accident on a fishing boat in his extended family. So I think this did contribute to heightening his post-traumatic stress disorder. And also at the workplace, on the positive side, he had very supportive coworkers who phoned him, at home when he was away from work. But there was also not that much support from the employer, in the sense that when he went back to work, rather than respecting his limitations, they actually kind of put him right back, on a boat, and he went on to experience, a lot of concentration and focus problems, and he had a near-miss experience. So this was rather problematic, but the near miss, I think, really heightened the attention and attracted the attention of people to this this worker, and more, I would say, respectful workplace practices were instituted. He didn't have to go back on the ship. And eventually what this fellow actually decided to do was to retrain in heavy machinery, but not on a ship. So I think this is an example of how everything is focused on function, also where the workplace is important, and where not everything is about just a diagnosis and treatment. The workplace was hugely instrumental. Initially, I think they had a negative impact, and then they started to realize that this guy really could not go back on the boat, and eventually it made more sense for him to go in a more of a vocational retraining path. So what the ICF model does is really highlight, I think, what is communicated by the research in this area. One, work disability is a person-environment interaction. It's also a social phenomenon, so it's not strictly medical, and it's also multi-partnered, involving the workplace, the worker, the clinicians, and the insurers. We haven't spoken that much about them, but they're also very much part of the picture. So what I'll do now is talk a little bit more about the prognostic factors of work disability absence. And what we did there, we looked at main systematic reviews and also some critical studies when there was a bit of a gap of information. For instance, in the systematic reviews covered, there wasn't that much information on organizational factors. So we went to more critical studies about those factors and to supplement the information. This is probably not the most standard review of reviews approach, but that's kind of, what we had, and we didn't want to miss that element of organizational factors. So in terms of main themes of predictive factors of work absence, so in the first domain, and I'll spend a bit of time on this slide, are the employee factors. One thing that we find is that the return to work, the expectations about return to work dates and about recovery of employees and workers are very accurate. So the bottom line, in a way, is like, just ask them when they think they're going to go back to work, and you're actually going to get a pretty accurate prediction. And that's because they're able to kind of scan and understand all of those factors in their environment and the messages from the doctor and the messages from the employer to arrive at a fairly accurate prediction of when they're going to go back to work. Their own motivation does come into play, but it's impacted by these other factors. The presence of pain, pain intensity, and also radiating pain keeps coming up as a predictive factor. And I think by demedicalizing return to work, sometimes we've wanted to forget the centrality of pain, but really it remains a very constant, prominent factor in return to work. Symptom severity, coping mechanisms. Are they using, ways for mental health disorders to decrease their arousal, with physical conditions to develop more positive self-talk, for instance? Those are all important. I won't spend too much time on the, psychological aspects. Drug and alcohol abuse certainly have a negative impact, and as multimorbidity, as we'll see later on, has also a negative impact on return to work. For the workplace, the most critical factor is available and suitable and safe modified work accommodation. Now, in those words, there's really a lot that's involved, and we're still trying to unpack what a good work accommodation process is, and it's very individual. It's often a very iterative process between the workplace, the clinicians, the worker. It's a very complex process, and I think that's one of the areas that needs more study. But we know it's important to have a work accommodation offer. How to get there is still something that we need to understand further. The role of the supervisor also recently is really emerging as a critical element because they're really at the juncture of the worker and the workplace demands and sometimes the limitations and restrictions about work. So and there's more and more training for supervisors to, for instance, identify who might be having a mental health condition and also to help people back at work, whether it's physical or mental. Psychological strain, so high demands, low control, Karasek model, I'm sure everybody's familiar with that. Workplace culture as well, respect and support are really getting more attention as very important factors. If you're going to go back to work in an environment where you're being bullied, called names, your workload is unreasonable, and you have the supervisor from hell, essentially, you're not going to be motivated to go back to work. In fact, people without any health conditions won't be that motivated to work. So clearly it has an impact. Presence of abuse, violence at the workplace, for instance, in the healthcare system, has also been found to be important. And perceived injustice. So this is where people may feel that they're being treated unfairly at work, and that seems to have a very important impact on the return to work process. With healthcare, so the clinicians still have a fairly protective stance towards their patients, obviously, and that's their training, is to help them and to protect their health. And yet, I think some of them fail to realize that going back to work can actually contribute to somebody's positive mental health. So having a bit more of a work focused in their interventions seems to really beneficial. And sometimes that's just a matter of sensitization of the healthcare providers. Continuity of care seems to be important. And finally, facilitation of the communication between the physician or psychologist and the employer. This could be through a return to work coordinator or directly. It's very difficult to have, for instance, a physician on the phone, but through letters or formalized forms, that seems to be quite effective. In terms of non-work environments, social support from family, friends, and also financial concerns. Financial pressure will certainly motivate people to go back to work a little bit more quickly sometimes. And in terms of the insurance, the main themes that are emerging are really about perceived justice of workers' comps. So we're seeing that what we call claim-related stress or perceived injustice, and sometimes, plain anger about the system. Whenever those elements are present, they slow down the return to work process. Delays in claim processing will also do that as well. So you can see that there's a number of different systems that are impacting on the process, the workplace, the healthcare system, and the insurer system. Time is very important in return to work, and this is kind of a classic survival curve where you have the survival curves of 3 different types of MSK conditions: upper extremity, lower back, and whiplash. And they're all very similar. And obviously you see that, so on the x-axis, you have the time, the duration since the workplace injury. And then on the y-axis, you have the percentage of people who are still on benefits, which clearly goes down over time. What you notice from that is first, so those little lines, so people have spoken about return to work in terms of phase specificity. So the first phase corresponds to 0 to 6 weeks since the workplace injury, which is the acute phase, which is really a good time to identify people who might be at risk for more prolonged work injuries. So, oh yeah, I have this little thing. So people who end up still being off work, a year after the work injury. The subacute phase refers to the period between 6 and 26 weeks. And we typically see this as a therapeutic window because what you can see is that the curves really flatten after 6 months. And whether you look at work outcomes or health outcomes at 6 months, whatever you've got at 6 months typically is what you'll get 1 year, 2 years later. It really flattens out, and there's a definite kind of chronicity that happens around 6 months. So your window of opportunity is kind of before the 6 months. And that's a very important notion to remember, especially when you're working in workers' comps where sometimes there are delays, and time is really always of the essence. The chronic phase refers more to the rehab, vocational retraining phase after workplace injury, and I won't be spending much time about that. But it's important to realize that the determinants of work disability, the interventions, will vary for each phase. So the first phase is really about early identification. Subacute is more about intervention, and then the chronicity requires a different type of intervention, such as rehab. So it's quite well established that the small proportion of claimants, about 10%, progressing to prolonged work absence actually explain 80% of the cost for employers and compensation systems, which is why it would be very nice if we could identify them right at the beginning of a claim. There are measures, screening tools that are available to do that. I won't discuss that in depth today, but suffice it to say that depending on where you use them, the screening items that would identify the long-term workers who will be on prolonged work absence, it's going to vary by context. So if you ask about those items in a medical clinic, it's going to be quite different than what you'd get as items that are predictive if it's a case manager at Worksafe BC that's asking the questions. Workers will present in different ways, and that's totally normal. They may talk to their doctor more about their use of opiates than, for instance, to their employer. Okay, so something to keep in mind. If we focus on the therapeutic window, what do we know that works in return to work? As I've mentioned before, the workplace component and the integration with the workplace is critical. Clinical approaches alone will lead to purely good clinical outcomes. They're going to feel better if they get clinical intervention, but they will not necessarily go back to work. And just a bit of data about that classical randomized controlled trial, which really the findings have not changed that much since then in terms of new information for MSK workers. So this was the Loisel RCT. And what you can see, so he's compared the combined Sherbrooke model, which involves both workplace and clinical intervention. So what you can see, if you compare it with the other standard clinical and occupational interventions, is that over a 5-year period, the gains and the differences are more, if you look at those green boxes, in terms of income replacement 5 years after the intervention. In the first year or so, there are not huge differences. But when you look at the outcomes 5 years later, that's where you really see the impact of a combined approach. So that's kind of the main message of that slide. In terms of where does the evidence come from, really, I should kind of speed up here. So if we look at the main systematic reviews that were conducted, what we can see is that in 2005, the systematic reviews included only 10 studies focused on MSK, musculoskeletal. If we look at 2009, there was one mental health condition that was added. This was a Cochrane review. Georgia Pomaki and I then did a systematic review looking only at mental health conditions, and they were comparative studies, not RCTs only. And then we look at 2013, and we do have one RCT for another health condition, cancer, and then 4 on mental health conditions. So we can see a progression in focus from MSK, then to mental health, then to health conditions. By and large, what we're seeing from these systematic reviews in a nutshell is that workplace-based interventions are effective in reducing work absence, particularly for MSK conditions, and the evidence is not that strong for mental health conditions. That's the same for the outcome of functioning, but when you look at health outcomes in general health, so more subjective outcomes, quality of life outcomes, there's not that much impact from those interventions. And I think what this really speaks to is that, one, return to work is really hard. And when you try to assess quality of life and subjective well-being when people are actually going back to work, the impact of the intervention is not that observable because they're not feeling that great. But over time, you're seeing that they have a better job retention. They do stay at work. And the fact that they're actually going back to work will have a positive impact on their finances. But in a nutshell, the evidence is much stronger for MSK conditions than mental health conditions. So what exactly is working in those interventions? So taking a more kind of human approach to this. So a lot of the qualitative studies conducted with workers' comp claimants really suggest that their experience can be quite difficult. So they report that they feel there's a lot of suspiciousness about the legitimacy of their complaints and their condition, their stigmatization. Delays, they feel disrespected and they feel ignored. So I think that everybody involved doesn't really want the workers to feel this way, and it's a very powerful, I think, experience when they have to deal with so many different systems that they don't know. They're complicated. They get letters at home they don't understand. They have specific delays to respond. It's a lot of stress for somebody who's dealing with a health condition. So the question is, how can we make it more collaborative and a better process? So in terms of best practice for MSK condition, what we find in terms of the findings of systematic reviews is that, one, the provision of work accommodation is key. Return to work coordination, so to have somebody who is outside of those systems to try to get everybody on the same page, where typically maybe a third-party return-to-work coordinator really is helpful in terms of eliciting more labor-employer cooperation, involving the supervisors and also the healthcare providers who are so hard to catch in a way. Presence of goodwill was one of the first findings of the qualitative review by Ellen McEachen, where what was apparent is that if there's no goodwill, and I would add if the workplace culture is not optimal, you can throw as many evidence-based treatment and interventions to these people. If there's a lack of goodwill, not much will actually happen. So it's a very human process, and it's a lot about interactions between systems, but also between people. And finally, the education and training for managers and supervisors is critical, and that really has been gaining a lot of attention recently. For mental health conditions, the best practices are a little bit different, and they actually address more the treatment element than for MSK. And that may be because getting effective treatment for mental health conditions is probably harder than for physical conditions. And that may be the case even more so in Canada, which it's notoriously difficult to get access to mental health specialists such as psychiatrists and psychologists. The GPs are taking care of a lot of the mental health conditions, but they typically may have like 10, 15 minutes, a patient to offer. So what we found with our review in 2011 was that the workers definitely benefited from helping them with navigation through the claim processing, whether one intervention only consisted of having a pamphlet sent at home clearly describing the process with the delays. It was that simple, and there was a huge impact in terms of return to work outcomes. The facilitation of access to clinical treatment. So again, it's very hard to get effective clinical intervention, especially in Canada. If there's a preferred pathway that's expedient, there was a study by Carolyn Dua in Toronto which showed that expedited access to a psychiatrist who was well-versed in workplace issues really had a very positive impact on work outcomes. And then the clinical interventions need to be work-focused. So if somebody with a mental health or depression goes for cognitive behavioral therapy, if that program actually addresses work and how to deal with their supervisors or to communicate with their coworkers or simply to get gradually exposed to the work situation, that will be much more effective than if work is not discussed, which is typical of most CBT treatments for depression. In terms of what works for stay at work for workers' condition with chronic condition, there we really need to move away from an acute onset model. So people with chronic conditions, the concept is a little bit different. You don't have an accident that starts your chronic condition of diabetes or of an endocrine disorder. It's much more gradual. So they're more focused on work adjustments than work accommodations. And the adjustments are things like healthcare benefits, flex time, work at home. And this is recent work from Monique Gignac, who showed that those were the kinds of things. It's those little things that made a difference for people with work conditions who are still working. There's a bit of a tension in this field between the health promotion model, which is about self-management, and an organizational culture model, which is about organizational practices around flexibility, around sick time, etc. What's also been found is that the chronic conditions seem just to have a magnifying effect on what bothers most workers. So, for instance, if you're really bothered by your workload at work, that's going to be present for most workers, but for somebody with chronic health conditions, that's going to be magnified, and they probably reach their threshold of I can't deal with that stress much more quickly than people without a chronic condition. It's also been found that age, economically disadvantaged neighborhoods also magnify the effect of chronic conditions. And we're starting to see RCTs looking at more self-management for people with chronic conditions. So those are, as you can see, they're all developments in the last 3 to 4 years. I'm going to just move a little bit more quickly here. So I'm going to talk about a study that we conducted, and actually some people here were involved in this study, Mika Cohorn and people from IWH. And I've chosen this study, well, not because it's the best study, but because I think it really is a good example of the multiple factors involved. The reason that I had problems with this study is that it was cross-sectional, and I like longitudinal studies and cross-sectional studies. I always find them problematic. But despite the fact that it's cross-sectional, I think it had such a rich database that it's really worth kind of discussing. So what we did there is that we recognized that given this very kind of large model of the person and environment interaction to explain work disability, with that model, there's very few studies actually who had looked at those two families of factors, workplace and worker, concurrently. And that's what we set out to do, was to look at those factors concurrently and also to look at multimorbidity in a large database of Canadian nurses. So why Canadian nurses? One, because it's probably the industrial sector that has the highest rate of absenteeism, but also because we had a really nice data set. We had close to 19,000 Canadian nurses, a response rate of 80%, and a very rich and broad variable set, which was very exciting. So what we did briefly is we looked at self-reported cumulative work absence duration over the last year due to physical and mental condition combined. And that was also difficult to live with because it was an outcome that was really a little bit messy, physical and mental, but we went with that. The predictor variables, sociodemographic, worker, job level, occupational, organizational, and we use structured equation modeling. In terms of the worker health factors, the multimorbidity that we ended up looking at was all pain related. So back problems, migraines, and arthritis, which were the most common health problems reported, apart from allergies, which was higher in prevalence, but we just didn't really feel that it had that much impact on the work absence. We actually checked that, and we checked it and we chucked it in a way. We looked at depression in the last 12 months, so prevalence of 9%, pain severity in the last 12 months, cause of pain, and pain interference, which is an important concept. It's their subjective report of how much the pain interferes with their work activities. Workplace factors, the culture, respect and support, presence of abuse and assault at work by patient or visitor or by coworker, and other work factors. So we found that 19% of them reported a work absence of 11 days or more, which was our outcome. That was our cutoff point of 11 days or more within a year. And also that close to 30% of more reported an episode of pain that was moderate, severe, or unbearable. And the number of conditions were very similar to what we looked at earlier in the presentation. So we did some partial modeling in the sense that we first modeled the worker variables and found that multimorbidity was really driving the experience of depression and work-related pain severity. The work-related pain severity impacted on the work-related interference, and the depression was directly factoring in the prolonged work absence outcome. When we looked at, we did a second partial modeling of the workplace factors, and we saw that the workplace culture was factoring into the respect and support at work. And the emotional physical abuse was a very strong factor, clearly feeding into the workplace culture. And then we did which was I think was the most interesting part of the study, is that we put the two models in and we looked at the interactions between worker and workplace. That was kind of, the first idea in a way. And we saw that respect and support directly mediated the experience of depression and of work-related pain severity. And again, work-related meaning attributed to, not work-related pain severity, like attributed to a work-related injury. So just to show you, we did our homework. We have all the coefficients. I'm not going to go into this, but I think the main point is that The worker health factors explained about 30% of the variance, whereas the workplace factors only 7%, but this was statistically significant and definitely improved the fit of the model by putting them together and also looking at their interactions. As mentioned before, this was cross-sectional. It was only females doing direct care. And there was a distinction between mental health and physical outcomes that was absent. The strength-rich database, and then we really did have enough statistical power to examine the various interactions between worker and work environment factors. So we can conclude that pain-related multimorbidity was a strong driver of prolonged work absence. Pain and depression were highly prevalent in a sample of Canadian nurses, and we saw the interplay between the work environment and the health conditions. In terms of practical aspects, we can say that promoting healthy workplace culture is actually work absence prevention. So that link is definitely present. Violence prevention in hospital settings is also work absence prevention. This had a huge impact on whether or not they were taking time off. And also work-focused pain management and depression management programs would be helpful. So in terms of moving forward to solutions, the types of solutions that I see as emerging as being quite important is one, to focus on screening and early detection of workers who are at high risk of prolonged work absence, and to also develop work-focused interventions, particularly for mental health conditions. For workplace factors, I think it's important to integrate the mental health and the multimorbidity aspects in work accommodation processes and in what we now call work adjustments, which I think are beginning to be a kind of a new concept in this field, and to improve workplace culture. For healthcare providers, keep the focus on work and facilitate that communication with the workplace. For insurers, we are seeing this kind of slowly happening, but to move away from a disability focus to more of an ability focus. And that will take time, but I think that it is happening in insurance systems. And to also avoid the dichotomization of work disability. So for instance, some people are discouraged by doing a work trial because if they try going back to work, they may lose some of their benefits if it doesn't work, so that they prefer to not take that chance. And I think there's a lot of different incentives that can be tweaked in insurance systems just to help people try and see what they're capable of. Facilitate the workers' navigation of the system. And for the funders, I think the question is who owns work disability? I think that multiple CIHR bins and multiple funding bodies are trying to determine who's going to be funding that type of research. Historically, it's been the workers' comps. And there's been more funded by non-workers' comps agencies, but I think that it's still a challenge sometimes to position a grant about work disability depending on which funding body is involved. I'm going to skip the key messages. I think I will let you look at them later and make up your mind about what you're taking away from that. And just to open up the question period, I've put on a few questions to stimulate discussion, but I'm sure that you have your questions of your own. So thank you for your attention, and we have a few minutes for questions now.
Thank you. So I'm just kind of wondering what the evidence shows in terms of like workers that are returning to the same job or a modified job take longer to return to work. And in terms of injury, if a worker is returning to the same work, are they more prone to repeat injuries than workers that are returning to modified work?
I missed just the first part of
Oh.
what kind of what, sorry?
Like before a worker
Oh, yeah.
returning to the same job, do they take longer to return to work than workers that are returning to modified
Okay.
job?
Okay, I got it. Generally, the outcomes are typically better when a worker goes back to the same employer and even same position, if it's possible. What happens, at least in the workers' comp system, and certainly for other insurance, is that you first have to determine what we call limitations and restrictions. So limitations is what's more difficult for a person to do. They might be able to do it, but maybe not as long or not as well. Restrictions are really what the person can't do for safety reasons. So they may feel like they can drive a piece of heavy machinery, but a restriction would be that they can't because of medication effects or concentration or focus, etc. So that's going to determine whether or not they can go back to same job, same employer. So in terms of what's best or not, I mean, generally the return to work process is facilitated if a person is deemed to be able to go back to their previous job with the previous employer. And the next step would be a different job with the same employer. But of course, the proviso is always that the restrictions and limitations have to be respected. In the case that I discussed, this young man had limitations and restrictions, but they weren't really respected, so it really kind of did not create a good return to work process. And eventually his best outcome was actually vocational training and different employer. So it's all predicated on the idea that you have to respect the restrictions and limitations, and once that's done, generally, if you go back to the same position and then same employer, it generally is easier than if you go through vocational training or go to a different employer. It's also hard if you have a health conditions to start with a new employer. That has its challenges. I mean, if people have been working somewhere for years, they have that history with the employer, and it can facilitate the return to work. And I say can with a bit of a if or but there, in the sense that sometimes with work disability, if you're dealing with an employee where there's been a lot of performance issues, for instance, it's quite common to see the employer responding this either consciously or unconsciously as an opportunity to maybe not take that worker back. Or sometimes you see that these performance issues were not mentioned, and then there's a work disability event, and they all come out, all of the work performance problems of the last 10 years. So when you try to help this employee back, it's much more difficult because sometimes there's going to be a concurrent human resource complaint that comes out of this, and this is not that uncommon. So, there's a lot of ifs and buts in this answer.
Thanks, Renee-Louise. It was a very comprehensive overview on a lot of different issues. I was intrigued early in the talk about the policy piece and the lack of kind of work mentioned in a lot of different policies. I'm interested in your perspective on where you think the policy levers might be for work accommodation and work, what was the other phrase, work adjustments?
Adjustments, yeah.
And in particular, the role of unions, because they've played a big role historically in those employment relationships, in terms of full-time work, part-time work, salaries, all of those kinds of elements. So I'm interested in your thoughts on the policy levers.
Well, my thought is going to be fairly blunt in the sense that I think that the lever is money. And I think that there's a case to be made about the positive impact of retention of employees and in terms of helping people stay and return to work, retaining productive employees. And the business case for return to work has been made already. For the stay at work, I don't think it has been made, but I think it's there in the sense that if you help people stay at work, I think in the long run, the employer and the worker are better off. I think the lack of focus initially with the reports that I covered, they seem to be largely based in the healthcare system, and they were probably developed with the contribution of a lot of clinicians who are focused on prevention and self-management and good, the delivery of good healthcare, which made total sense. And I think in the training of physicians, of psychologists, I can speak for myself too, there really was not, up to recently, a lot of focus on the role of work. And the role of work, I mean, generally, if you continue to work, there's been a recent study that, it's a lot of people talk about, work disability and mortality. But, generally, if you're able to work, you're going to be in good work conditions, your health is going to be improved. So I think that element still needs to be, that message needs to be disseminated to clinicians and to help them achieve, kind of a good return to work, stay at work program. That study by Gignac, the last one, was very interesting because one of the adjustments was, for instance, health benefits. And I didn't really expect that to be there, but it makes sense, right? It's like I say, it's sometimes those very small details in people's lives that makes a difference in terms of whether or not they can continue to work and do the other parts of their lives that they enjoy.
Okay, guys, we're just a little bit over time, so I think we'll wrap it up. Thank you very much, Renee-Louise.
Yep.